Good afternoon, everyone. Sorry for the delay, and thanks for staying all the way up to the bitter end. So I'm from Singapore, and hope to keep this quick. So I'm going to change track and talk about treatment-related toxicity, side effects, and like real treatment as an antiretroviral therapy, not alcohol. Okay, and I'm a clinician scientist, so I see patients with HIV all the time and treat them all the time, and I'm interested in pharmacology, so I decided to look at this problem. So I'm just going to talk about renal disease in HIV, kidney disease in HIV patients, and then talk about Tenofovir, and then talk a bit about our Singapore data. Okay, so chronic kidney disease is an important effect of antiretroviral therapy. Even with HIV, you get renal disease, but even after controlling the HIV, you do get kidney disease. And the studies have shown that chronic kidney disease does go up with even after from 2% to 6%, even after effective antiretroviral therapy. So there are a few reasons for this, and there are factors like increased age and ethnicity that you cannot control, but there are also those that we can control, and I just mentioned that you can control the HIV nowadays, but you can also control blood pressure and diabetes and hepatitis C now, but I'm going to focus on antiretroviral therapy. So there are our medicines that control HIV can cause kidney toxicity as well. Okay, so and one of those that does this is called Tenofovir. So Tenofovir is given as the fumarate ester, and it's a nucleotide analog of a reverse transcriptase. So it's like a nucleoside, but it's a reverse transcriptase as well. So this drug is quite similar to adafovir and cidofovir, both of which cause a lot of renal toxicity, and this is not supposed to cause so much, but it turns out that it does a bit as well. So this drug is very effective. This is the old slide, but it showed that once we started Tenofovir, the success rate of treatment is more than 80%. So this is a very, very good drug. More than half of my patients on this drug is on all the first-line recommendations for HIV treatment. Okay, so it's a very commonly used drug. So, but the problem is whether this drug causes kidney toxicity. And this, like I said before, this is similar to other known nephrotoxins, and it accumulates in the renal proximal tubule, and is mainly excreted in the urine. So you have the Tenofovir that goes in through the OAT1 transporter and excreted to the MRP transporter. So if there are any problems with these transporters, you could get accumulation inside the proximal tubule, and then you can get toxicity in the mitochondria. So a lot of these nucleosides cause mitochondrial toxicity, and Tenofovir might do the same as well. So this is another picture of how the Tenofovir gets in here and gets out here, and there are a few transporters involved. Okay, so and this can cause accumulation and high concentrations of Tenofovir in the proximal tubule cells. Okay, so this is what might happen. You have the Tenofovir that goes in here, and then it forms a triphosphate. And this is a triphosphate that inhibits a HIV reverse transcriptase. So this is the active component. The only problem is it also inhibits our DNA polymerases in the mitochondria, and this can cause mitochondria to go down, and it might cause oxidative reduction in oxidative phosphorylation, and the cell cannot use the energy, and then basically it's toxic and stops working. And when it stops working, then you get your kidney failure. So this is the hypothesis, and the related drugs, adafovir and cidofovir, interferes with the transporter as well. And Tenofovir might do the same thing at high concentrations as well, and it might also downregulate genes. So there are a few reasons to think that Tenofovir might be toxic to the kidney. Okay, so before the drug came out, there were a few in vitro studies that showed that it actually shouldn't cause that much toxicity because it does not reduce mitochondrial DNA levels and doesn't have a lot of cytotoxicity. And then the epidemiologic studies came out. The phase 1 and 2 studies showed that there was no effect. And the clinical trials, so all these were sponsored by the drug company, Gilead. And they basically showed that there was no effect on the tenofovir on renal function. So this is like example of one of the trials, the GS903. Okay, so it looks good so far, so everyone is happy. Until this, so the conclusion from this was that there was no difference in renal events within tenofovir and placebo groups, and no tenofovir-related side effects. So they are looking at whether the creatinine clearance went down. Okay, so then this happened. So in 2002, people started reporting cases of tenofovir-related renal toxicity, and this was found to be a Fanconi type of syndrome, where there was a first report related to nephrogenic diabetes insipidus and Fanconi syndrome. And they did a biopsy, and they showed there was damage to the proximal tubules, so there was something going on. So this was caused by tenofovir, because when you stop it, the effect got better. So what we think might happen now is you have these proximal tubule cells, and what they do is they bring in sodium, glucose, and phosphate, and they also get rid of glucose. So when these cells stop working because of mitochondrial toxicity, it stops working, and then all these transporters do not work, and then you have all these glucose, phosphate, bicarbonate, sodium, amino acids that cannot go back. Sorry, this is the lumen, so this goes down into the bladder, and so you get all these, they are not reabsorbed, so you lose all this in the urine. So and that's called Fanconi syndrome. And the main problem with this is actually the phosphate, because phosphate is important for your bone. So you're realizing that this drug, tenofovir, causes a lot of reduced bone mineral density and fractures. So this was a problem that they found. So this literature review came out showing that they found 27 cases of renal toxicity after they started looking for it. And a lot of these were caused by in the older age group at that time, and a lot of them were also caused by people who were taking ritonavir, which is a protease inhibitor mentioned earlier. And and the diagnosis took about 1 year before you found it, so that was why maybe we couldn't see it earlier. And some had diabetes insipidus, and like 2/3 of them had Fanconi syndrome, and like 20% of them didn't actually recover, so they were not reversible, and some had protein as well. Okay, so this was what they found. And then there was other features as well, acidosis, so you lose bicarbonate, the acid builds up in your body. You lose your potassium, so you have low potassium in the body, and the tenofovir levels were high. Okay, so in all those cases, the low potassium, low phosphate got better, but the creatinine clearance decreased. That means the kidney function did not get better. So, and like what I said earlier, this can cause loss of bone mineral density and fractures in the future. Okay, so this study showed that there might be effects of drug-drug interactions as well. So the protease inhibitor ritonavir causes the tenofovir to go up by 30%, and the ritonavir also inhibits the MRP2, the transporter I showed you, and this could cause a decreased secretion of the tenofovir from the proximal tubule cells. Okay, and the same thing might happen with diadenosine as well, which we don't use so much, but we use a lot of ritonavir, so that is a problem. And then there's also studies showing that there are some pharmacogenomics, so if you have some mutations in your MRP, you can get a higher rate of toxicity. Okay, so this is the background, and so what happened was we started to look at this to see whether this actually happened in our cohort in Singapore. So this is some old data that was published by my colleague Arlene Chua a few years ago, and this was where we got our patients. So this is the Communicable Disease Center, which looks after about 3/4 of the HIV patients in Singapore. So this is the main HIV center in Singapore. Okay, and we did a retrospective review of all the patients who were started on tenofovir. And at that time, we were starting a lot of tenofovir. So we monitored them for 2.5 years. and we look at the creatinine clearance change, and we look at age, ethnicity, gender, diabetes, hypertension, hepatitis B, whether they had chronic kidney disease to start off with, CD4 count, and whether they're on ritonavir or protease-based, inhibitor-based regimen. So there were 226 patients who we managed to get data from, and most of them were male, like in Singapore, 90% male. And most of them were Chinese ethnicity, although we had Malays and Indians as well as in the usual population. 46 years old, 60 kilograms, about half of them were on ritonavir or protease-based inhibitor-based regimen. 26 had diabetes, 23 had hypertension, 2 already had chronic kidney disease, and 63 had hepatitis B. And the CD4 count was quite low, 127. So there were all these people, there were 2 who stopped because of renal toxicity, the rest continued. 11 had failure, and 3 just didn't like the medicines, so they changed. Okay, so this was the result of the study. So it looks quite, you just look at this, it doesn't look like there's much decrease. So, when they analyzed it more closely, they found there was a slight decrease in creatinine clearance, especially after the first year. So it's like 82 to 79, about 3. And then after that, it was about the same from then on. So this was what was published. Okay, so the creatinine clearance was 82. The normal is about 120, so it was low, and there was a reduction of 3.9 and 3.6. So it didn't look very significant, and there was no association with CD4 or any other things. So this was published, and when I took over this analysis from Dr. Chua, I decided that did they miss something because of the way they analyze it? So this is our new data that I reanalyzed, and this is being presented for the first time in an international conference. So this is the new data part. So I reanalyzed the data using a mixed effects modeling analysis. The software is called Stater, and the command is just called XTMix. Okay, and so I decided to look at, it looks like the percentage was going down rather than it's a straight line. So I did a log transformation, so it's a percentage reduction. And I included patients with, so not everyone had baseline creatinine measured, so I took out those without baseline creatinine. And then there were some funny results that did not make sense, so I took it out. Like creatinine clearance more than 600, which is not possible. Okay, so there are 165 patients left. And the results was, so the baseline creatinine clearance was 80, so it's about the same as before. And at baseline, the older you are, the lower your creatinine clearance, so as expected. So when you age, your kidney function goes down. And also there's slightly higher creatinine clearance if you are bigger. So not sure how this one works, but okay. So but the important part was what are the factors that cause this creatinine clearance to go down. So the first thing is that there is a 3% reduction of creatinine clearance every year. So we just saw that it went down by 3.9 after 1 year. It didn't seem very much, but if you put 3%, and these people are going to take the drugs for maybe 20, 30 years, so you might land up with 50% reduction at the end of their treatment after 10, 20 years. So that was a problem that we found. It was 3% reduction. And the older you are, the faster the creatinine clearance went down. So that's quite worrying as well. We have more and more patients getting older on HIV therapy. So that was an issue. This one was a bit, we didn't expect this, but if you had a higher creatinine clearance so you had better kidney function at the beginning, the more the creatinine clearance went down. So there's more proximal tubules to hit at, I guess. So it was opposite to what other people saw. And the older you are, the more protective it is, which also might just mean that the bigger you are, the less drug there is. There's more drug spread out all over the body, which is a reason maybe why we should reduce the dose for people who are smaller. So that's another thing that we found. But there was no effect on CD4 count or age. Age was here other than this, and and there's no effect on ritonavir again. So this was against what other people found, but that's about. And we didn't see any effect on diabetes or hypertension. So that's our results. So the conclusions was that the decline in creatinine clearance, 3% a year, actually after we did this study, other studies have shown that it's probably about there as well. So it's consistent with the literature. The problem is that if you want to look at this, it's not a sensitive measure because it's only 3%, but 60% would, or 60% of those with renal toxicity, or about 25% of those of all these people will have some kind of Fanconi syndrome. So we should look at Fanconi syndrome instead of just the creatinine clearance. Increased age and lower weight contributed to faster creatinine clearance decline, and higher creatinine clearance at baseline was associated with faster decline, and there was no effect of other parameters, but maybe we need to recruit more people on ritonavir. Okay, so what we want to do next is to look for the renal toxicity markers. So I mentioned about Fanconi syndrome. We need to look at urine glucose, amino acids, phosphate, beta-2 microglobulin, uric acid, potassium, and creatinine, which we haven't done yet. So we want to get these patients back and measure this. And we are trying to find new predictors for as well. So you can predict those people with creatinine clearance that went down using a marker like cystatin C or NGAL that could help us to stop these people on going on with tenofovir. Okay, and so we can measure tenofovir plasma concentrations and intracellular as well. We're developing the assay, and then we can look at mutations as well, like other people have done. So that's what we are trying to do. And so I thank all the HIV patients who provided their data and provided their samples along the way. So Tan Tock Seng Hospital, Dr. Chua, who wrote the first paper, Dr. Ng, who has taken over the database and helped me with the analysis, people at the National University of Singapore helping me with the biomarkers, and funding from the National Medical Research Council, which is the NIH in Singapore, and the National Kidney Foundation. So thank all these people, and thank you for the attention, and yeah.